This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I'm sharing my conversation with Dr. Mark Laslett as we discuss his new study, published in Musculoskeletal Science and Practice, exploring the effects of anesthetic and corticosteroid injections in patients with MRI-confirmed lumbar disc herniation. Dr. Laslett breaks down key findings on how patients respond to epidural injections, whether they experience immediate pain relief, a delayed response, or if their symptoms suggest an alternative diagnosis. We will explore what these response patterns mean for clinical decision-making and how they can guide a more personalized treatment plans. Dr. Laslett is a highly experienced New Zealand-based physical therapist with 55 years in the field. He holds diplomas in manipulative therapy and mechanical diagnosis and therapy, and earned his PhD in 2005, focusing on diagnostic accuracy of clinical exams for chronic low back pain. As the first physiotherapist registered as a specialist by the New Zealand Physiotherapy Board, he has taught extensively worldwide on topics like the lumbar spine, pelvis, hip, and diagnostics. He also co-founded Southern Musculoskeletal Seminars, an online education platform, and has authored over 40 publications, including the book Mechanical Diagnosis and Therapy, the Upper Limb. If you work with patients dealing with radicular pain or want to optimize epidural injection outcomes, this episode's for you. If you find our conversation informative, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues in the clinical field who could benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Neck Care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi, Mark. Welcome back to PT Pro Talk. How are you today?
Very well, thank you. Thank you for inviting me.
Awesome. I'm excited to discuss your brand new paper just published. So let's just start talking a little bit about yourself and your background for the ones that don't know you yet.
Fine. Continue.
Do you want to give us just a brief overview about you, your career? Yeah, brief, Mark. I know you have many years of experience.
When you're 75 years of age, you know it's there's too much history. In essence, I started private practice on my own account in 1971.
Oh wow!
And I've been in private practice ever since. So I am a clinician first and foremost. I got involved in research in the early 80s. I did study philosophy of science before that, and I started being actively involved in research in the late 1980s. I have always been fascinated by diagnostics as a clinical science, as distinct from therapeutics, which is the usual focus for physiotherapists. You go to courses, you go to conferences, the talk is all about what treatments can I do? What is the outcome of treatments? Does it work, et cetera, And whilst those questions are entirely valid, my interest and passion has always been, what are we actually dealing with here? What is the source and cause of symptoms? And that's diagnostics. And so I became fascinated by the whole issue of diagnostic test reliability and diagnostic test accuracy in the early 1990s. And my PhD, which I started when I was aged 51, back in 2001, I started that, and I tried to do a PhD out of New Zealand, but they wouldn't let me do the PhD I wanted. And so my very good friend, Professor Birgitta Oberg in Sweden, offered me the opportunity to do my PhD in Sweden, which I did and completed in 2005. My PhD was done. The reason why I did this PhD was because I had this opportunity to work with Dr. Charles April. He's a radiologist whose specialty is interventional diagnostics in the spine. And we started going to I was traveling a lot, and I was passing through the United States a lot, and he's had his own clinic in New Orleans. And I was dropping in like 2 or 3 times a year for several days to see patients with him. And I started doing that in the mid-1990s. And we did the sacroiliac joint study between 1996 and 1998. And then I started my main doctoral thesis of doctoral research in 2001, 2002. And we in the sacroiliac joint study, we saw about 80 patients, all of whom had diagnostic injection into the sacroiliac joint. And in the studies between 2001, 2002, I included in my doctoral studies 218 patients that I fully examined, and Dr. April would do various interventional diagnostic procedures like provocation discography, like facet joint blocks, sacroiliac joint blocks, epidurals, etc. And so we accumulated that data, and I published a number of papers as a consequence. And in fact, one paper, a couple of papers are emerging now, even now, based upon the data we accumulated in 2001, 2002. And so that's still being published. When I finished my PhD, I didn't get a job in academia, although I had intended to do so. I went back into private practice on the request of a colleague here in the South Island of New Zealand, and so I really didn't finish publishing all my data. And we're talking about 218 patients, of whom there are something like 600 or 700 variables from each assessment. There is an enormous, when talking about facet joint blocks, sacroiliac joint blocks, provocation discography, epidurals, we did all the psychosocial variables, pain intensity, pain drawings, and all of that. When you take all that information, and it's like 600 or 700 variables, and I only ever managed to publish 6 papers out of that, or 7 papers. So we're still actually processing that data, and I'm doing that in collaboration with a colleague in France whose name is Jean-Philippe Deneval, who has just recently completed his PhD on his own data, but he now has all of my data, and he's reanalyzing it. He's done all the data entry quite separately from what I did, so we've got completely independent data entry verification, and now we're continuing to publish, or starting to publish, some of the data that should have been published back 20 years ago. And I've been in clinical practice all this time, except for when I was doing my PhD, and at the age of 75 or 74 last year in April, I finally retired from clinical practice. Although, to be fair, I'm still seeing patients occasionally, but I sold my practice to Joe Kennedy, who's now taken over my practice, and I'm just seeing a few patients when she gets too busy.
Before we continue our conversation, I wanted to take a quick moment to present you to our sponsor, Urban Pulling.
Welcome, PT Pro Talk listeners. Looking to enhance your rehabilitation practice or promote active aging? Urban Polling Inc. has you covered with our evidence-based activator polls and program, trusted by over 10,000 therapists worldwide. These unique polls, designed by an occupational therapist, improve stability, posture, and mobility for individuals with conditions like Parkinson's, stroke, arthritis, and ortho rehab. Visit urbanpolling.com/PTProTalk and enjoy an exclusive 30% off on CEU-approved courses and 20% off for activator polls.
And now, let's get back to our conversation. That's over 50 years of practice?
55.
55, wow. Yeah, many years of
Well, I
practice.
really am a clinician. I mean, I like to think of myself as a clinician scientist in that order.
Yeah, absolutely. And for the ones that are listening to us, we recorded an episode over 4 years ago, February
It is.
2021. That's just flew by, 4 years, episode 27. So if people want to go back and check, it was about lumbopelvic spine diagnosis. I just thought about it when you were talking about your experience and your diagnostics interest. So if people want to go back and listen to that one, it was a great episode. So Mark, let's now dive into your paper. Do you want to talk a little bit about, it was just published, right? Now 2025.
Yes, it was published basically this year. Yeah. In a Journal of Musculoskeletal Science and Practice.
Okay.
Yeah.
So go ahead.
It's actually a very, very simple paper. It's not simple in some respects, but in principle, it's quite simple. And it's something that the sort of study design is something that physiotherapists in the right environments can do easily. It's not that difficult. And so it could be replicated, or it can be validated, or even refuted if people wish to do that. That's fine. Basically, what we did was I still work, but I have worked for at least 5 years now, but even going back further, but mostly working in an environment where I work closely with the local emergency department. And we see acute, severe, disabling back pain patients. Practicing as a physiotherapy specialist, and in New Zealand, that is your specialist physiotherapists are actually registered by the government in the same way as medical specialists are under the same Act of Parliament. So I was the first physiotherapy specialist in New Zealand to be registered as such. There are now 20. Now remember, we only have 5 million people in New Zealand, so it's not that. So the proportion has to be seen in that light. So 20 is actually not too bad. And anyway, so as a specialist, what happens is that I've been working closely with the emergency department doctors and physios since 2015. When we attempted to do some research, because the doctors in the emergency department are aware that back pain patients are common. In the emergency department at our local hospital, 3 or 4 acute severe back pains turn up every day. All right, so that's about 2,000 a year. And now in everything else, the protocols in the emergency department require what is called time and action specific follow-up. In other words, if a person has chest pain and turns up at the emergency department, they look at the patient, they try to reach a diagnosis, they manage the patient as required, and when the patient is referred or discharged from the emergency department, either to the hospital or to the community, an appropriate follow-up is required, and they have protocols to ensure that there is a time and action specific follow-up. Now, I coined the phrase TASFU, TASFU, time and action specific follow-up, TASFU. But they have TASFU for everything except back pain. All right. And so I was approached by one of the doctors there, and we started working together in 2015. And in 2019, when I went back into practice as a specialist physiotherapist, they continued to send me patients. And of course, these patients are patients who have not satisfied criteria for admission to hospital. In other words, they go in there with a severe back pain, but unless they have Quarter-Equina syndrome, or an infection, or a fracture, or they have some serious problem that requires that the patient be admitted and have an MRI immediately, all right, then they're discharged to the community, regardless of how intense their pain is. And so this is so what they've been doing is they've been referring patients to me and my colleagues with these acute severe back pain. So you have people with acute severe lateral shifts and kyphosis, and most often they have radicular pain. They have pain radiating down the leg, and our task is to determine whether or not an MRI can be justified, and can it be managed conservatively, can it be managed with just medication and physiotherapy, or does it need to go on to have an MRI, and then if a prolapsed disc is identified, do we go on and do epidural injection, or do we send them straight to the surgeon? And so I have this very close relationship with two neurosurgeons, mostly, some orthopedic surgeons as well, but mostly neurosurgeons. And so we have this very, very tight network, and where the surgeons and the ED people, that's the physicians and the physiotherapists who work at the ED, we have this very tight network where they trust our judgment as to what is required. And I've worked closely with one of the neurosurgeons now since 2012, I think it is. And so he knows that when I say, look, we need an MRI, he doesn't need to see the patient. He just writes out the form. Now, one thing that we can't do I can refer a patient for an MRI, but the government won't fund that unless it's referred by a medical practitioner, even though I'm a specialist. We still have to work through the surgeons or the musculoskeletal specialists. So we have this trust relationship with the surgeon. If I say this patient needs an MRI or this patient needs an epidural, it's done within 24 hours or 48 hours.
That's great.
So we have this very, very tight, very clean pathway for patients who are in severe pain. So what we did was, over a period of about 2 years, we accumulated 50 cases, about 50 cases, with acute radicular syndrome. These are not people who just have back pain and a shift. These are people with acute radicular pain that do not satisfy criteria for being admitted to hospital. All right. Now, 66%, about 2/3 of the patient came from the ED. The other third came from the community, but most of these came from the ED. And so what we did is we had a protocol. Now, when I started doing my PhD back in 2001, I developed all the documentation for measuring pain intensity before any procedure, be it epidural, be it facet joint block, sacroiliac joint block, discography, whatever, and then measurement afterwards at 1 hour, 2 hour, 4 hour, 6 hour, and then afterwards later on. That protocol started in the PhD, and I've been working on that documentation system very, very consistently for 20 years. And now we have PDFs that the patients are given, and then the data is collected on 100 millimeter VAS scales, and we measure back, buttock, and lower limb pain separately, because a lot of people they might have radicular syndrome, but they don't always have leg pain, which is dominant. They can often have back or buttock pain, which is dominant, although they have radicular symptoms and signs. And so we measure these things separately. And then, and when these patients they're not suitable for conservative care, in other words, when they're in such severe pain, it's really hard to move these people around. Okay, you can't just say, "Oh, let's do some push-ups." It didn't work like that. Not with these patients. A lot of patients that I see, we can push them around, do lots of repetitive movements, and we look for centralization and directional preference and all that sort of stuff. And it's really possible. But in these severe cases where they can barely move, they're on crutches or they're on, we haven't had anybody carried in on a stretcher, but we've had a few that are pretty bad. And most of them are very uncomfortable, and you can only do a limited amount of assessment with them. And so we say, okay, looking at you today, I think we need to get an MRI to find out if you've got a prolapsed disc. And then we send the patients off for an MRI. And if they do have a prolapsed disc, then we say, now you have choices. As a patient, I explain to them all about natural history, about how 75% of people get better in 3 to 6 months if we don't do anything at all, and these, even though you might have a big prolapse, the chances of that shrinking down over a year is very high, so the prognosis is not bad, but it's not perfect. So right now you have a decision to make as to whether you want us to give you an epidural steroid injection to see if we can help you with the pain. Mm-hmm. Because the prognosis is good, so we don't go operating on you just straight away unless the pain's so severe or the disability is so severe that it has to be done right away. So we give the patients the choice as to whether they go ahead and have an epidural injection. Mm-hmm. So what this paper is about those patients who selected or opted not to go to surgery, or not to have a first surgical assessment, and not to have an injection, but to see what would happen with natural history. So this is 50 patients who say, look, I'd like the help to see if the injection would help. And so we sent these patients, we got the MRI done, confirmed the disc protrusion or prolapse or herniation or sequestration or whatever. And we said, okay, now we know where to give the injection, so the patient goes away for a CT-guided injection. And we give the patient, and we teach the patient how to measure their back, their buttock, and their leg pain the morning before the injection, and then 1 hour, 2 hour, 4 hour, and 6 hour post-injection. And then they follow up with me in the clinic, or my colleague, Joe Kennedy, in the clinic 1 week later. Now, the reason for that protocol is twofold. One is that first 6 hours tells you about whether you've injected the right place. Mm-hmm. All right. So in other words, if you put an anesthetic into an area that is not the source of pain, you'll get no change in symptoms. Right? Mm-hmm. If you do put anesthetic where the pain comes from, you will. It's actually really simple. You go to the dentist and they will select what they think is the painful one. They'll tap on it, or they put cold on it, and they'll say, that's the one. And then they'll anesthetize it. And if they don't anesthetize the nerve that supplies that tooth, the pain doesn't go away. Mm-hmm. It's exactly the same in the back. All right. If you get an anesthetic response in that first 6 hours, then you know that the anesthetic has reached the source of the nociception. Okay, so that first 6 hours is all about how do we know where the pain is coming from. Mm-hmm. All right. Now, obviously, epidural injection is not a precise injection. It goes into the epidural space and around the sleeve of a nerve root. And so it's a bit of a blunderbuss type of injection, but it does include the nerve root, possibly the dura mater that surrounds the nerve root out to the dorsal root ganglion, and also some of the anesthetic will leak into behind the posterior longitudinal ligament and part of the annulus. All right, and so you can be sure that if the patient gets a good pain response, a positive pain response, a reduction in pain immediately following that injection, then you know that the stuff has reached the target tissue. Now, not all patients have problems which are the same. For example, we know that some prolapse discs have a largely mechanical effect on the nerve or the dura mater, all right? And it's just purely the pressure, or the tension, all right? Mm-hmm. If the nerve is stretched over a prolapse disc, all right, or it's compressed against in a narrowed foramen or something like that, that mechanical pressure, that's one issue. The other issue is you can have a much smaller, less mechanically invasive prolapse, but it produces an inflammatory response.
Mm-hmm.
And so when we inject cortisone, dexamethasone or something like that into that space, then if there is an inflammatory component to the patient's pain, then they will get a response that is a positive response from day 2 through to day 7. So in that short, and if within a few days, that inflammatory response will be markedly reduced and the pain will reduce accordingly.
Mm-hmm.
So what we have when we do an anesthetic and corticosteroid injection is the opportunity to do two things. One is to determine if we have delivered the material to the right structure, and secondarily, to determine whether or not that has an inflammatory component, or is it actually just simply mechanical pressure, tension. All right, so that's what this paper is about. We took these 50 or 60 patients and we measured their pain and we analyzed their responses, and we broke it up into anesthetic response and corticosteroid response. And so we determined very simply that for about over 40% of people had a marked anesthetic and corticosteroid response. 20% of patients had neither a corticosteroid nor an anesthetic response. And another 40% had an anesthetic response but no corticosteroid response.
Mm-hmm.
Now that has very significant implications from a therapeutic point of view. Now, most people think of an epidural injection as just a treatment. It's not. It has very significant diagnostic implications.
Mm-hmm.
So the question is, which level is affected? Now, this is really important when you see patients with radicular pain and other things, but radicular pain we're talking about, as to which level it is. Is it L5S1? Is it L4-5? Is it L3-4? Is it L2-3? Okay. And many patients have more than one protrusion.
Mm-hmm.
And sometimes more than one is symptomatic. Now, that's not common, but it does happen. All right. Okay, so most of them, you see, you have a prolapse disc, and it's usually one. It's very obvious. It's one level on one side, and that's it, or it's in the middle or whatever. Okay, and so you can, but predicting the level clinically is actually not that easy. In fact, many orthopedic and neurosurgeons have joked about when they say, "Oh, clinically, I think this is an L4-5 disc protrusion, causing L5 nerve root pain." They'll joke because they say, "I'm going to get it right at least 50% of the time, just by guessing, because 95% of all protrusions are at L4-5 or L5S1."
Yeah.
So if I say it's L5S1, I'm going to get it right about 50% of the time. If I say it's L4-5, I'm going to get it right about 50% of the time. So, and they joke about it, and it's true. But the epidural injection tells you it is or it is not that level. That's the anesthetic response.
That's what I was going to ask you. So to get the right response, it needs to be on the right level.
Absolutely.
You can, like, if you have more than one level, for example, that's painful, then you got to do two different.
We in this study, we did find several patients who had more than one level, and we had to inject two different levels.
Okay.
Because the first injection had no anesthetic response. But even if they have a corticosteroid response, if they don't have an anesthetic response, we know that we injected the wrong level.
Yeah.
And that happened. That happened not often. Well, I think it's 3 or 4 patients with whom that happened, and we had to go to the level above or the level below, and then we got the anesthetic response.
And how do you assess that? Palpation,
No,
muscles
no,
or
no.
anything?
Just the pain response by the patient. The patient tells you on the documents.
But I mean, like, how do you know that's the right level when you're gonna tell the surgeon the level that
You don't. It's a guess.
Oh, it's a guess.
But you've got a 50% chance of being right. But it's only an injection. It's not surgery. See, that's why we do these things before surgery, because if we've done the injection and we've analysed it properly, we know to tell the surgeon, or the surgeon knows that that's the level and that is not the level, so he'll operate on that level. So his chances of operating on the right level first time is very high.
That's a good point of view.
You see what I mean? So that's why we work so closely with the neurosurgeons, because they value that information, and we don't. They don't bother trying to do all this stuff. They just leave it up to us. Mm-hmm. And the radiologists generally don't measure before and after pain very accurately at all. We as physiotherapists do that, and we do that very, very well. And if you allow me to share my screen, I can probably show you. You can't do that.
Mm-mm.
No, okay.
But
the documentation for the PDF forms where the patient fills out or puts a mark on a 100 millimeter VAS scale, that's available off my website for free.
Uh-huh. And
then you can so now the important thing is that these VAS scales for back, buttock, and lower limb pain. They're 100 millimeters long. So if the patient puts a line on that 100 millimeter line, that's your percentage. Mm-hmm. So if you measure the number of millimeters from 0 and it comes to 30, that's 30%, isn't it? That's 30 out of 100. Mm-hmm. So in other words, if you tell the patient that 0 is nothing, that 100 at the end of this line here, that is the worst pain imaginable. Now, you have to explain what that means, because patients misinterpret this all the time, and it's very culturally dependent, all right? For example, you have a lot of people say, oh, this is 110. No, there is no 110. It just doesn't exist. It's useless for data collection. So what you say is, all right, at the end of that line, all right, that's the same sort of pain that you'd expect if I got hold of your hand and I get hold of the patient's hand and I put it in a fire and I held it there and I wouldn't let you pull it out and you're screaming and yelling and the skin's coming off and it's going black. That's at the end of that line. And you're not screaming right now, so it can't be more than that. That's what I say to patients. They all get it.
Yeah.
Right, so don't give me anything more than 100, because I don't want to know about anything that's more than 100. You're just exaggerating. It's less than 100, and it's if it's there at all, it's more than 100, more than 0 and less than 100. So it's somewhere between 0 and 100. So that data gets entered into an Excel spreadsheet, which I have also put on my website, which is downloadable for free. It's a very sophisticated spreadsheet where you enter the patient's name on the first page, and that automatically transfers over to the second page, where you put the data in, and then it calculates the percent change in pain before and after, does all of that, and then on the third page it's all graphed out and looks very pretty. Nice. So you can actually see graphically the change in pain intensity for back, buttock, and lower limb pain intensity, and the average is calculated as well. So it takes the back, the buttock, and the leg, combines all those scores and divides by 3. So you get an average of the overall for the whole picture. So that's all put on a graph, and the graph itself is nice and pretty, and it calculates it shows you the anesthetic response, and then if you put in the 1 week data later, you can see the corticosteroid response, because they're quite separate. The anesthetic is gone by the time the corticosteroid is starting to act. Mm-hmm. So that's very, very important. So this paper is about this immediate response. What's the diagnostic implications of the epidural injection in this particular subset of back pain patients that typically are in severe pain? All right, because we as physiotherapists, these are the people we can't immediately help as physiotherapists. These people need to be managed with their pain, with medications, with injections, and if necessary, go on to see surgeons and the like, and get MRIs and things like that. So that's what this paper's about, and it's attracted quite a bit of attention, I have to say.
And let me ask you before I forget. So like when you first send the patients to get an MRI, right? And when you predict the level, it's usually the same level the MRI shows?
Usually, but not always. Don't always get it right. I get it right maybe 80, 90% of the time, but there's an error margin, absolutely. One of the things that we found in this study, that 20% of the patients, even though we believe they probably had a disc protrusion, and that was confirmed on MRI, when you do the injection, this is one out of 5. When you do the injection, there's no anesthetic response and there's no corticosteroid response a week later. So in other words, what that tells us is that 1 out of 5, that's 20% of the patients who we thought might have had a prolapse disc causing their pain, didn't. In other words, it's a diagnostic error.
And it's not the wrong level. It's just that's not the right, maybe the pain is not coming from there, or do you think it's like do you think it's the wrong level of
well, it could be, but that's usually not the case, because if, for example, if the patient has, we think that they have a prolapse disc, got pain radiating down the leg, and they've got severe back pain or leg pain or both, and we say, look, we'll get an MRI. We get an MRI done, and there's a prolapse disc. So we assume that that is the cause of the patient's pain, right? So when we put a needle in there, we put anesthetic around there, and they get no anesthetic response, that means that that prolapse disc is not causing this pain. Now, if there was no other prolapse discs anywhere, where are we going to inject next?
Good question.
See the point? So in other words, this is a diagnostic error. It's not a prolapse disc causing this pain. It could be facet joint, it could be sacroiliac joint, it could be something else. But one of the things that is not reported in this paper, but is important to understand, is that when we're accessing these people who are in severe acute pain, we can't do a full examination. You can't get them to heel and toe walk. They can barely stand. You can't. When they do big toe extension and big toe flexion and ankle eversion, all right, when they do big toe extension, they say, oh, that hurts me. And so it feels weak, but it's not weak. This is just a pain reaction. It's a pain response. All right, we use straight leg raised imitation. As soon as you move their leg, they go, oh! And that's just overreaction. They're in agony. They're scared. They're painful. Some people are terrified that they're going to be like this forever, or they're going to die. All right, it's it's a very unpleasant pain. Some of these things, and so we take these patients at their word, and we get them to have an MRI to make sure we're not missing a fracture or an infection or a cancer or something like that. We get an MRI done, and if we see a prolapse disc, we give them an injection. All right, and 1 out of 5 people that we sent off for have this procedure had no responses to the injection. So
crazy.
That's why you don't operate on people just on the basis of the fact that they got leg pain. Because 1 out of 5, it'll be nothing to do with it at all.
Yeah. And in that case of patients in that level of pain, that's a super helpful diagnostic too.
Absolutely.
Because you can test them, you can't do anything.
That's correct. The thing here is that those patients are generally patients who are they are overreacting. You can call it what you like, right? But they're panicking. They're full of anxiety, and we have measures of all of these patients have to do questionnaires. We do the pain intensity scores, of course, but we also do the Roller Morris Disability Questionnaire. We do the Central Sensitization Inventory Score, and we do the DASH-21. Now, the DASH-21 has 3 parts. It measures anxiety, depression, and stress. All right. So and these are simple measures that any physiotherapist can do. And by the way, we get this, the patients do this before I even see them. I do it online. I've got a system which is managed by a company called Quick Q&A, and all of my patients get sent a link before they even see me, and they have to fill out the questionnaire before I see them. So I have all that information about their sensitization, about their pain intensity, about depression, anxiety, stress, and disability. All of those measures, standardized measures, are with every patient I see anyway. So that's fine. And we have all that information. Of course, we have the other information like, medications and what have you, but we've got all that data. And so when we look at these patients and we decide, I can't really physically examine you very well, but we're going to get an MRI and see if there is a prolapse. And if there is, we'll do an injection. But 1 out of 5 of those cases that won't have a response. And so these people are generally, this is a psychosocial, neurophysiological enhancement of symptoms, and we treat that as such. We say to the patient, look, we've had an MRI, there's your prolapse, but that might have been there for years without pain. And it's currently not causing pain either because we put anesthetic around there and it didn't switch the pain off. So you have nothing to worry about. Then we do the fear avoidance, the anxiety thing. We do that cognitive behavioral therapy, if you want to call it that, where we teach them, look, you're not going to die. You have an MRI. You don't have a serious disorder. We do all of that. And if sometimes within days, the patient is feeling 90% better because of all the relief of that, all that terrible anxiety and stuff. And so you have to manage these people in a psychosocial way rather than in some sort of mechanistic way with inflammation or compression of a nerve root or something like that. So we've absolutely acknowledged the fact that 1 out of 5 of these patients have a significant psychosocial impact on the experience of this pain. And we treat them as such. That's not a problem at all.
And like on those patients, do you think most of them are psychosocial, as you mentioned, or you think they could just have other sources within the spine or other, like as you mentioned, facets and sacroiliac joints or?
It varies quite a bit. But I mean, I don't think the psychosocial is a cause of pain. It is an influencing factor. All right. It is something that takes away, it strips away any inhibition to pain experience. Normally we have lots of interacting pain suppressant procedures going on in our spinal column and hindbrain, which are completely under the level of consciousness. It's subconscious, or not unconscious, but subconscious. And so that's all happening. When you have a person who's highly sensitized, all that, the gates are open, right? And so small amounts of nociception cause huge amounts of distress and pain, all right? And so what we do is we do this, the cognitive behavioral approach to this, and the sensitization levels come down, and then we can thoroughly examine them. And we often will find that it's something else, like it could be sacroiliac joint, or it could be facet joint, or it could be deep gluteal pain. It could be a hip joint problem, which has just emerged and it's been misinterpreted as being coming from the spine because of the particular pain distribution. And then we get an MRI to show there's been there's a prolapse there, and so everybody assumes it's a prolapse. Well, it's not, because we did the epidural to that prolapse, and there's no anesthetic response. It can't be that.
Yeah.
It can't be. You know, and I know that if you cut your hand and I put anesthetic on there, the pain stops, and they can sew up your wound. It's just. Do you know of a case, really, a case where the anesthetic on a wound like that does not anesthetize it? It always does.
Yeah.
Every emergency doctor knows this. Every nurse knows this. All right. So if you put an anesthetic on a place where the nociception from which it arises,
Mm-hmm.
it switches it off temporarily.
Okay.
And that's what this is about. You measure that as a diagnostic tool.
And then, like, I remember I read that the psychosocial factors did not influence, right, the tendencies of the patients to follow in one type versus the other. So on those patients that you just mentioned, you didn't identify that prior to?
Well, we have identified that, but that's the numbers in the study are not sufficient to do the analyses that allow us to interpret whether or not what the likelihood of somebody falling into that diagnostic error category versus the mechanical category versus the inflammatory category. We didn't really have enough data to do a lot of analysis of that. That probably would require a couple of hundred patients.
Mm-hmm.
So that, although I do believe that the psychosocial factors and sensitization, which doesn't have to be psychosocial, by the way,
Mm-hmm.
I've been measuring using the central sensitization inventory measure for probably, well, since not long after it came out. So it's like probably 10 years now.
Mm-hmm.
And so I've been using that ever since, and I find it to be extremely valuable in identifying people who you have to manage somewhat differently, all right, depending on how high that score is. I mean, you get scores of 55 or 60 out of 100, all right. You can't do a repeated movements assessment on that person to see if they centralize, because everything makes them worse.
Mm-hmm.
Right? It's really, really hard. And even if they do centralize, the back pain becomes so severe that they can't continue.
Mm-hmm.
So you have to be the psychosocial dimension and the neurophysiological dimension, which is the sensitization issue. Those factors influence how much diagnostic testing you can do and how you need to sometimes modify your therapeutic interventions in order to get the optimum results.
Mm-hmm.
But you do not treat people with a prolapse disc by talking to them and saying, "Oh, you're going to be okay."
Yeah.
That just doesn't work. If you've got a prolapse disc and it's a mechanical type that's pressing on the nerve, you can cognitive behavioral therapy these people until the sun sets, until the sun dies.
Yeah.
And it will not make the slightest scrap of difference. All right. These people have a pure pathoanatomic source of pain.
Yeah.
And it hurts like hell. And it hurts like hell for a long time. And it can be very, very disturbing. In fact, people have to realize is that radicular pain, this is pain that comes from pressure or inflammation around the nerve root, is known to be a factor in producing depression. People with confirmed radicular pain from a prolapse disc have significantly higher depression scores than any other back pains. On average, that's an average,
Yeah.
But so radicular pain is a very disturbing thing, and it causes great anxiety too. You imagine if you're a 30-year-old woman and you've got 3 young kids and you suddenly have a prolapse disc. How are you going to look after those kids?
Yeah.
It's really, really difficult. You know, if you're a guy who works manually, and you're on, a worker's wages, and your boss says, when are you going to come back to work? And he's got this raging leg pain. How's he going to deal with that?
Mm-hmm.
Is he just going to tough it? You can't tough this out. You can't just be a powerful, strong person and say, "Oh, I can't. I can ignore this and continue working as a farm labourer." I'm sorry, it doesn't work like that. You can't work with this sort of pain any more than you work with a broken leg. So these are very real phenomena, and you can psychologize these things endlessly without any effect whatsoever. There is a component that's really important. That part of it is really important. But 4 out of 5 cases, it's not important.
Mark, and do you think psychosocial factors could predict the type 1? Or do you think that everybody that has that type of pain would have some involvement? Like it would not be helpful to predict that?
In this study, all of those patients had a prolapse disc on MRI or had a protrusion that seemed relevant to the clinical picture. So we did not do epidurals to people who didn't have these prolapse discs or whatever. They all had that. So we can't say if the psychosocial factors predict the pain. You just can't. This study is not capable of doing that. It can only tell you about people who have MRI-confirmed prolapses. And in those people, the epidural shows that 1 out of 5 of those prolapse discs are not symptomatic, even though they have leg pain or intense, what appears to be intense back or buttock pain of radicular quality.
So you can predict like the psychosocial would be, if they had those factors, they would be more likely to be type 1.
No.
Okay.
No, because the people who have true radicular pain, they are very often score high on the DAS Quest 21 or the sensitization. And as soon as the pain goes away, it all kind of returns to normal.
Yeah. Okay.
In other words, what comes first, the chicken or the egg?
Yeah.
If you have the severe pain and you have many responsibilities in your life that you can't fulfill, or you're just simply afraid of what this might mean, all right, then you may well become depressed or highly anxious or sensitized, right? That's a consequence of the pathology, right? Then you have those people who have psychosocial distress issues and for physiological sensitization issues, then they prolapse their disc. Right? And then there's some people who have those psychosocial physiological issues and they get pain without a prolapse disc. Or something else. So, it's not simple black and white. There are many subsets.
Yeah. One of my questions, I was like, do you think is any way to predict how those people are going to react before you do the injections?
Not really.
No, right?
But again, I wouldn't take that as gospel. And the reason being is that this is 50 patients. Right? We did not do the analysis. We were unable. We did do some analysis, but it was the power of it was not sufficient for us to report much on that. And that's in the paper, by the way. We actually put that in the paper. We need this is like a pilot study for something. If you want to look at that in detail, you need at least 200 or 300 patients, I suspect, to see if the psychosocial factors can be, or if there are predictors of those 3 categories that you can do before you do the injection. But at this stage, all right, I don't believe we can say we can predict that.
Okay. And just a question about the injections. So in each injection that you did, you had anesthetics and the corticosteroid together?
Yeah. Well, they do the anesthetic first and then they put the cortisone in. Okay. Sometimes doctors mix them up together and they put them in simultaneously. Most of them put an anesthetic first and then they put the corticosteroid in. So they put the needle in and then they have a cannula, they have a leader, and they just change over the syringe.
Okay, but they do it at the same time.
It's all done at the same time, yes.
Okay.
And it's in a single procedure.
Okay. And do you want to tell us about the 2 and 3 now? Because that's going to be the different responses to the analgesic and the corticosteroid.
Right. The type 2 and type 3, which we have chosen to call this mechanical versus inflammatory. Mechanical ones are the ones who get an anesthetic response but no corticosteroid response. In other words, yes, we've injected the right level, but it does not appear to be, and we know that the cortisone has been delivered to the same place, and so there's no corticosteroid response. So it's not inflammatory because cortisone will stop the inflammation like that. It really does. And it does that very, very powerfully for at least 2 weeks. Okay. I mean, it takes 2 or 3 or 4 weeks for that to be completely metabolized. and washed out of the system. So you're going to have a corticosteroid response for 2 or 3 weeks, all right, at least. So at 1 week, which is when we did the follow-up, if you don't get a corticosteroid response in a week, you're not going to get it. If the patient gets better over the next several weeks, that's not enough, because they might be getting better anyway. All right. They have to have, usually you'll start to see a corticosteroid response within 48 hours. The patient will notice the improvement, quite rapidly within 2 or 3 days. And by a week, the corticosteroid response is at its maximum effect. Right. So if you get an anesthetic response, you can say, yes, the prolapse disc that we see on MRI is relevant. And no, it's not inflammatory. It's mechanical. Okay. It's pressure or tension on the nerve root or the dura mater that's causing this. Okay. Then that's the mechanical category. The inflammatory category is the where you get both an anesthetic and a corticosteroid response. Okay, that means that the patient says in the first 6 hours, I had at least an hour or two where the pain was substantially less. All right, and it doesn't have to be ablated completely. It can be, but we set the margin at around 50% reduction in pain, and it has to be 50% reduction. Now, any less than that is probably not. That might be just placebo effect. All right, but the reason why we chose 50% is because the anesthetic is a weak anesthetic. It's not a full strength anesthetic. It's not like when they do a tooth, where they use a strong anesthetic. They use a weaker version of the anesthetic, because if they anesthetize the nerve completely, the patient can't get off the bed and walk. All right, because the nerve is completely paralyzed.
Yeah.
All right. So you're not expecting 100% relief of pain, although it does happen sometimes. Right. The reality is that the most people who get an anesthetic response will get 50 or more % reduction in pain, and then they'll go on, and that will last for hours, sometimes 1 or 2 hours, and then pain all comes back again. All right. In some individuals, the pain never comes back. Never comes back. Now, that does require some explanation, and we think we know why that is. All right. But because the cortisone doesn't work within an hour or two. It takes at least 24 hours, usually 48 hours, before the cortisone is really starting to have an influence. And so if you get both an anesthetic response and a corticosteroid response that is still there, the patient is still significantly better at 1 week, then we know that we injected the right level, and yes, it has a large inflammatory component to it. All right. Now, how does that change how we treat people? Now, obviously, the 20% of patients, the 1 out of 5, where we have a diagnostic error, we manage that largely psychosocially, with cognitive functional therapy and all that sort of stuff, which is fine. All right, but the 80% of patients who have either a type 1, a type 3, or type 4, a type 2 or type 3 response, as mechanical or an inflammatory response, the people who have a mechanical response, we know that doing another injection ain't going to help them. Because we injected the right level, but they got no corticosteroid response. So there's absolutely no point having another injection. That's for sure. So the question is this going to resolve naturally? Because the prognosis is rather good. So we say to the patient, look, if you are in severe pain and you would like to get a surgical opinion about whether the surgeon should operate or not, we can arrange that, and we can arrange that quite soon. And the patients can choose whether or not they want to go through that process. That's what we have done with our patients. And I would say 50% of the patients will say, look, I'd like to have that surgeon have a look at it, and they then might go on to have surgery or not. Now, you've got to remember that time is passing all through this process. And some of those patients are getting better and better just through the natural history within a few weeks. And so by the time they get to see the surgeon, all right, it's been a couple of weeks maybe, all right, and they're already 50% better, the surgeon and the patient will say, look, let's just see what happens. And they don't have surgery. But if they're getting worse or they're staying as bad and they're terrible pain, and they get to see the surgeon in 2 or 3 weeks, and the surgeon says, look, we've got a prolapsed disc, you had a positive response, but no cortisone response, and you're not getting any better, you can wait 3 to 6 months to see if it gets better by itself if you want, but I'm happy to operate on this. And most patients will say, for God's sake, operate on me. I don't want to be in this pain anymore. And the success rate is very high. The patient wake up. They go to sleep before the operation with terrible leg pain and back pain. They wake up and all they've got is a bit of back pain. Within days, it's just so much better. A good surgeon does a good job, and it's a very successful operation. Particularly when you've had that diagnostic workup and you've selected your patients as carefully as we do. You get really, really good results.
Even if it's mechanical and you know that potentially if they can endure the pain, they might respond to conservative treatment?
Yep. If it was me, I'd have the operation if it was that bad. Yes, I would.
Yeah.
I mean, why wait? 6 months in agony. Why wait?
And you're not even 100% sure that you can resolve it mechanically.
You don't know that. You have to wait it out just to see. And then you imagine being the patient and having terrible leg pain. You say, I've had patients, by the way, who refuse to have surgery. That's their choice. That's fine. They're not going to die. We don't force them to have surgery. And they say, and then 3 months later, they're still in agony. And they say, can you operate now, please? And then they wake up 2 days later and they're virtually pain-free. And they say to themselves, oh, why did I wait so long? I mean, seriously, that happens all the time.
And do you see many cases that they wait and subsides and then they respond to conservative treatment are not very common?
Oh, yes, of course.
Yeah. Okay.
Yeah. Oh, absolutely. Let me tell you a story. This is not in this patient in this study, but this is a fellow whose name is Peter. Peter is a patient I saw back in 2010, I think it was. And he's an Indian guy, very religious Indian, Hindu. And they believe in collective prayer, where if half of India is praying on your behalf, then somehow God will solve the problem, right? I mean, they really believe this. This is part of their culture and part of their belief system, which I totally respect. Anyway, he had this massive prolapse. I mean, it's huge. It's just really massive. And he saw the surgeon, and the surgeon says, I want surgery. He wants to do surgery. This is very, very big. We need to operate on this. And Peter says, oh, no, I don't want surgery. And so then the patient comes to see me because the surgeon says, well, go and see Mark Laslett and he'll see what can be done conservatively. And I look at Peter and he's got straight leg raised limitation of 25 degrees on both sides, causing raging leg pain. So he's got crossed straight leg raise, he's got a weak big toe, and he's got this and he's got that. And everything fits. I say to Peter, I really think you should have the surgery. This is a very large prolapse. And he says, I'm not going to have surgery. I'm not going to have surgery. Okay, Peter, all right, that's fine. There's a chance that you'll get better by yourself, okay? So he goes away and he's got an appointment for 3 weeks later to see the surgeon to finally determine whether or not physiotherapy has been of any value to him. So he goes away and he and half of India are praying on his behalf. And he gets to see the surgeon, and the surgeon says, how are you, Peter? And Peter says, I'm fine, I have no pain. He's still got straight leg raised limitation of 25 degrees, but doesn't hurt him anymore. Okay. So the surgeon says, I'm not going to operate on you if you have no pain. So he sends the patient back to me, and I examine him, and mechanically he looks exactly the same, but he's in no pain. He has no pain.
That's crazy.
Not crazy. Call it what you like. Call that a placebo effect. I have no idea. So I said to Peter, this is fine. We'll get you in the gym. So I sent him to my colleagues at the gym, and he starts on a gym program. He loses about 10 kilograms in weight. He feels better. He feels much more empowered, and he reckons that half of India praying for him has worked for him. And 6 months later, we are at a function at the gym. There's a 10-year anniversary party, and Peter's there. I said, Peter, you look fantastic. How are you? He says, I haven't felt this good in years. And his wife was there. You can probably cut this piece out. His wife was there. She says, it's really, really good. Very good in bed now. True. She was great. So go figure.
Yeah.
I mean, seriously, you have the Peters of this world who absolutely believe that God or nature or whatever is going to solve their problem. And there is a strong placebo effect. You can explain that however you wish, but it's real. And that's why we always work. This is where the therapist-patient rapport, this relationship, is so key to getting good results. If you work with the patient, you don't force things on patients. You give them the information, say, well, it's your body, it's your life. Here are the options. You can select. Now, some people are uncomfortable with even choosing. They just want you to solve their problem, or they just want you, what would you do, Mark? Or, what would, if it's your back, what would you do? I'd say, I'd get an operation. Well, no, I just have the injection, or no, I'd live with that. Okay, I'll do that then. Some people can't make decisions like that.
Yeah.
All right. And so we have to be sensitive to the variation in human beings.
Yeah.
So, yeah.
And what percentage was the mechanical type? Do you remember on the paper?
Say that again?
The percentage of cases that were the mechanical type?
37%.
37. Okay. And then how about the inflammatory one?
That was 41%.
41. Okay.
By the way, that's just another important point here, is that if you take 100 patients and you give every one of them an epidural injection, you're going to get 60% failure rate by 1 week and 40% success rate. Now, all of these systematic reviews on epidurals will tell you that epidurals don't work. Well, of course they don't work. If you lump them all together as though they were the same thing. They're not the same thing. There are subgroups in radicular syndrome.
Yeah.
And only 40% are going to be steroid responsive. But that 40% are steroid responsive. So you can't condemn epidural injections when there's a 40% chance that the patient will be dramatically improved within a week. So you use your epidural injection as a diagnostic procedure, all right, to help select what management's going to look like. It doesn't determine exactly, because there are patient preferences and all those things. Now, I've just learned from my colleague Jean-Philippe Deneval in France that where he works in Poitiers in France, the radiologists do these injections, these epidural injections, and they don't use anesthetic at all. They just use the cortisone. And that's a mistake, because you have the opportunity to, when you're doing these injections, you have the opportunity to determine if you've actually injected the right level or not.
Yeah.
The problem with just doing steroid injection is twofold. One, you don't know if you're injecting the right level, and you don't know if that patient is getting a systemic inflammatory response or a local anti-inflammatory response. For example, we know from work that was done in Sweden on shoulders, They had a whole bunch. They did a whole bunch of. I think it's Epidural et al. It was 15 or 20 years ago they did this, and they had these people with shoulder pain, with presumably subacromial pain, like the rotator cuff or bursa, and they injected 50% of the patients. They did a local injection in the shoulder that was painful, and the other 50% they did the same injection into the opposite buttock. And overall, the results were roughly the same. In other words, the steroid injection, regardless of where you inject it, gives a systemic corticosteroid response. And you know this from your patients will say they have an injection for a knee problem or a shoulder problem or whatever. And they say, oh, by the way, this other problem, which I've had for years, has been really good too.
Yeah.
You hear that all the time, right?
Yeah.
So that is why you have to do the anesthetic response, because just because you get a corticosteroid response from an epidural injection doesn't mean to say you've injected the right level. It just means they're getting a corticosteroid response, which is systemic as much as it is local. Obviously, if you put the corticosteroid exactly where the inflammation is, you're going to get a much more powerful effect than if you inject somewhere else in the body.
Mm-hmm.
Because it's obviously, but you do need to know whether or not you are injecting the right level or not, the right structure.
Mm-hmm.
So this paper gives us that information.
And then talking about management, so how do you manage the inflammatory type? So you know that they respond to corticosteroids. So then how do you go from there? Do you see their symptoms, re-inject them?
Very good question. That's obviously, if the patient's pain has gone from 80 out of 100 down to 5 out of 100 or 10 out of 100, then they're going to be very happy with that. And the question then remains is, does it stay better?
Mm-hmm.
Okay. Now, if the pain starts to come back again at 3 or 4 weeks as the corticosteroid is metabolized, that tells you that the cause of the inflammation is still there.
Mm-hmm.
In other words, if it's the prolapse disc, it's the nucleus that is in the disc that is degrading into inflammatory products that's causing the pain. The cortisone has merely suppressed that, and if that process of degenerative change causing the inflammation is continues, right? Once the cortisone is gone, then the patient has to have a choice. Do you want to try another injection?
Mm-hmm.
Do you want to live it? Do you want to see it through to see if the body will resolve it itself? Or do you want to go and see the surgeon to see if you want the prolapse taken out? So again, we will review the patient in 3 or 4 weeks once the cortisone has been, this is not in that paper, by the way, but this is what we do clinically. Mm-hmm. We will review the patient in 3 or 4 weeks, bring them back and say, okay, how are you doing now? What's your pain intensity? We'll get them to do the pain scores again. And if the pain has come back, the question is, how much has it come back? Mm-hmm. Is it now back to where it was? Or is it back? So if you started off with a mean value of 70 out of 100 and went down to 5 out of 100, and now it's come back to 30 out of 100. Is that a failure or is it a success? The answer is, ask the patient.
Mm-hmm.
If the patient can live with a 30%, that 30 out of 100 pain, and then wait out to see if the pain will finally go away, that's the patient's choice. If the patient says, I'm really unhappy with this, it's come back to 50 or 60, it's still really disturbing, I can't work, then you get the patient to go and see the surgeon or have another injection. They have choices. Mm-hmm. We give the patient choices. Mm-hmm. And by doing that, we don't run into the problem of treatment failure as such. We don't expect any treatment to be successful in every case. That's just that sort of expectation is silly. Mm-hmm. Surgeons don't expect that. Physiotherapists shouldn't expect it either. And the people doing these injections don't expect it. So the bottom line is we have to work with the patient as to what's acceptable.
Mm-hmm.
All right. Can you live with this pain? Yes. Do you want to live with this pain? Yes. I'd like to see if it'll get better by itself without the surgery. Fine. Let's follow you up. Let's get you in the gym. Let's do these things. All right. Oh, by the way, that's another important thing. During the time the corticosteroid is still present in the tissues, you should not be exercising this patient. Very important. This is true regardless of where you are injecting corticosteroid. Shoulder, knee, ankle, back pain, it makes no difference. It's all the same. Whilst that corticosteroid is present, any inflammatory response is suppressed. In other words, if the pain was at 80 out of 100 and you suppress the inflammation and the pain drops to 20 out of 100 and you get the patient back in the gym and they start working that painful tissue, it's no longer painful because of the cortisone, you're going to damage that tissue further, and so you'll get pain recurring after the cortisone comes back, and may even be worse as a consequence. Now, by the way, that's not, we know that this is true for the back as well as it is for other areas. In the studies we did on the shoulder back in, it's nearly 15 years ago now, with Dr. Angela Cadogan, we followed her patients up for 12 months after steroid injection and all that sort of stuff. And of the patients who had a recurrence of pain after the injection, the cortisone injection, 45% of those patients, despite our advice, actually re-injured their spine. They went out and did something, they did another injury. So a lot of the so-called failure of corticosteroid is actually failure of the patient to follow instructions. And instructions are, you will engage in relative rest for at least 3 weeks after an injection. It's really important. And the reason for this is because you do not want to load the painful structure when inflammation and the body's response to injury is being suppressed, because you'll just damage it further. So you wait until the corticosteroid has been metabolized, at least partially. And I would say no less than 2 weeks, preferably 3 weeks. And then there's only relative rest. They don't have to go to bed, but they don't do any loading. They don't do any weight training or training for athletics, or they can do a bit of walking. They can do normal daily living things, but they can't load that structure, even though it feels fantastic. All right, and that's a big mistake of doctors doing these injections. The patient comes back in 3 or 4 days and say, "Oh, I'm much better now, doc. Great, you can go back to training, and get your sprinting going, and we'll get you back." And it's a very bad management protocol. 3 weeks. I don't care how, I say to the patient, I don't care how good you feel. You will not train for 3 weeks. Now, a lot of athletes won't do that. And they have to bear the consequences of that decision. It's not my fault. It's not the fault of the injection. It's the patient's fault. And I tell them that. I'm very, very strict. All right, because you follow my instructions and you'll have the greatest probability for success. Now, if they follow my instructions and the pain does still come back, then the question is, what's causing the inflammation to come back? It's not a failure of cortisone. It means that we haven't understood the pathology well enough. All right? If you have an inflammatory process that's continuing regardless, the cortisone is not like a magic bullet. It's just a powerful anti-inflammatory. That's all it is. And you have to, once you understand that, you know how to use those things. But by the way, I've been working with corticosteroid injections since all my life.
And Mark, so when do you re-examine the patients for centralization?
I would wait 2 weeks. Wait for the cortisone to start being suppressed, for that suppression to be diminished by metabolic activity, and then you reassess. Just like I think Hans van Helvoort has done some excellent work on that regard. And then I would reassess to see if any residual pain can be centralized or if there's a directional preference.
If the patient tolerates, right? If their pain level is...
Absolutely. And that is only true. You can do that with type 2 and 3, both mechanical and the inflammatory type. But bear in mind, the inflammatory type, the people who do get a good corticosteroid response, you examine those 3 weeks later to see if it's possible to centralize or whatever. All right, any residual pain. If they have no pain, there's nothing to centralize. If the patient has the mechanical type and they don't get a corticosteroid response, you should still examine them once more to see if you can centralize the symptoms before making the final advice as to whether they go and see the surgeon or not.
And if, in your opinion, the mechanical ones, they're more likely to centralize than the inflammatory ones?
I don't know the answer to that. We haven't done that analysis. I haven't particularly looked for that. Hans van Helvoort may be able to answer that question better than me. But I personally have not done that analysis. I'm not sure.
Okay.
I would say that the mechanical type, no, I can't say. I don't know. No. I mean, it's tempting to say it's the mechanical type are more likely to, but I don't actually know.
Yeah. Okay. Fair enough. And you mentioned that sometimes the anesthetic one, the pain doesn't come back, and you said that you think you know why. Would you want to talk about that?
Sure. Back when they first started doing epidurals, which is a long, long time ago, and when they started doing facet joint blocks and sacroiliac joint blocks as well, again, this is like 40, 50, 60 years ago, they were doing just local anesthetic injections. That's it, no cortisone. And they noticed that as you inject the saline or the anesthetic, is that that reproduces the peripheral symptoms, all right, than the nerve root or the pain from the facet joint or the sacroiliac joint, and that just anesthetic alone can give a lasting benefit. Just anesthetic alone. So they get an anesthetic response, but the pain doesn't come back. The question is why? And the anesthetic's gone in 6 hours. So why does it stay better? Right? We've known this not just from epidural, but we've known this from everything. I mean, you go back and read Cyriax's books, and he talks about gluteal bursitis. And he doesn't inject cortisone to start off with at all, because he's found that just using anesthetic, that most of those patients get a lasting benefit just for the anesthetic. Now, is it the flushing of the tissue, getting rid of inflammatory exudates, or is it the needling itself that's doing that, causing it to bleed and then they get an inflammatory response which resolves and you get a lasting response as a consequence? Or in the case of the epidural, where they're not doing a needling approach, they're just flushing with fluid, are you just flushing out inflammatory exudates from the epidural space? I suspect that's what the case is in the case of epidurals, is that just for the anesthetic alone, the flushing is probably getting rid of the cause of a lot of the inflammatory response. And you don't need the cortisone, but you don't know that until you do it. Now, the first epidural, of course, the first epidurals were done, I think, before cortisone was even synthesized. And so they were doing epidural injections at the beginning of the 20th century of just local anesthetic. In fact, my belief is that the first epidural injections were done in the 19th century. In the 19th century, we're talking about 1800s.
Yeah,
all right, just after this discovery of local anesthetics. All right, this is before they even knew before Mixter and Barr's work in 1934. All right, They were people with sciatica. They were doing quarter epidural injections of cocaine, and some patients got better immediately and stayed better.
Mm-hmm.
The question is why? And the only real satisfactory answer is that yes, you can understand why the pain goes away when the anesthetic is there, but that does not explain why the pain stays away. And that we think that it's probably the flushing of the tissues, getting rid of inflammatory exudate out of the epidural space.
Mm-hmm.
That's hypothesis. That's hypothesis.
Yeah. And if you're injecting just anesthetics, do you think you could go and reassess when they're getting better without having to wait any longer to see if the pain would come back? If you would reassess for directional preference, for example?
Sorry, make sure I'm understanding what you're asking me here. Are you saying if we just use local anesthetics,
Mm-hmm.
right, and then if they get a sort of an improvement as a consequence,
Mm-hmm.
could we then try directional preference testing or centralization testing? Yes, that's fine, but why do that? You've already got the needle in there. Why not put the cortisone in too?
Mm-hmm. Yeah.
I mean, if the pain comes back after 6 hours, then you got to put another needle in there, and they've doubled the risk of infection.
Yeah. Yeah.
No, there's no real justification for not including the cortisone.
Mm-hmm. And on that type 3 that you said that if they get the injection and they get better, but then the pain comes back, so the inflammation is coming from some other place. In your opinion, what are the most common?
No. If you have an inflammatory response that is suppressed by cortisone, but after 3 or 4 weeks the pain comes back, that means that the same structure as producing the inflammation was no longer being suppressed by the cortisone.
Mm-hmm.
In other words, see what happens with disc protrusions and extrusions is that they go through a degenerative process. They actually break down. That's why they shrink. That's why we know they get smaller and smaller over a year, right? So we know that happens with a significant number of cases. And it happens mostly the more nuclear material that is inside that extrusion, the more it's going to shrink. If you have articular cartilage or end plate or annular material in the extrusion, that's not going to shrink. It's only the nuclear material that shrinks. And so if you have a large nuclear extrusion, then you're going to have a lot of breakdown of that material. We know that nucleus pulposus around the nerve root is very irritating to the nerve root. That was discovered by a Swedish orthopedic surgeon by the name of Rudovik. He identified the fact that the nucleus pulposus, not the annulus, but the nucleus pulposus has a caustic, or acidic, I'm not quite sure what it is, but it has definitely an irritating effect and causes an inflammatory response around the nerve root. We know that. We've known that since the 70s. So that's not new information. That's very old information, but it is true. And you see, when you talk to surgeons who do these operations every day, they'll tell you that some of the nerve roots look, the nerve is sort of white and pink normally, but some of them look bluish color. And that's because they're stretched around the protrusion, and that blocks the arterial supply to the nerve, and you get an anoxic effect. All right. And others look inflamed. They look red and sore and angry. That's an inflammatory response, probably to the nucleus breaking down. And so there are many subgroups here. And the cortisone injection, the epidural injection, is a way of trying to make sense of some of those variations that we see in responses to procedures and assessments. So that's pretty helpful. So you cannot, there's no singular solution here.
And if the pain comes back, then do you think they they are more likely to not respond? Or maybe if you do another injection?
No, I can't. That's one of the questions I can't answer. We haven't done that analysis. We haven't got enough patients. We haven't got enough power to be able to answer that question. It's a very valid question, I have to say, absolutely valid question. All right, but that's something that is for future research where we have sufficient numbers.
Okay. Well, anything else, Mark? We discussed a lot of different things. I don't know if I'm forgetting anything. Anything you want to add before we wrap up?
Well, again, this was a simple study, and we did it on backs and radicular syndrome, but exactly the same categorizations occur everywhere in the body. If you have a rotator cuff problem, you know and I know that some people get an anesthetic response and some people don't. You know that some people get a steroid response and some people don't. It's true in the shoulder. It's true in the hip. It's true in the knee. It's true everywhere. Now, the same categories exist. Some are diagnostic errors. Some have an inflammatory basis, which is very strong, and some is not. You confirm by anesthetic response that, yes, you've injected the right place, but there's no corticosteroid response. It happens in tennis elbows. So the same sort of study that we did on the radicular syndromes here can be done on every problem that we see in musculoskeletal medicine.
Yeah, that's a great insight. If people wanted to learn more about your work or contact you, where they can find you?
Okay, in the English-speaking world, Physio Academy, just Google, or nowadays you can grok it. You know, you can grok. Do you know what I mean?
No.
Do you know what? You don't know what the grok is? Okay, that's Twitter, now called X. They have their own search engine and their own AI called Grok.
Okay.
And it's just as good as Google. Anyway, it doesn't matter. You can get it's like Chat GPT, but it's very, very good. Anyway, you can Grok it, or you can Google it, or you can Chat GPT it. You'll find that that Physio Academy is run by Angela Cadogan, and my courses are all there. That's been translated into French and Spanish, and the Agence EBP out of France, they manage that process as well. Awesome. We haven't yet got it done in Portuguese.
Yeah, you got to translate. We have a big population in Brazil.
I know. I'd like to do that.
And I know you're also...
And of course, it's my upcoming book.
Yes, that's what I was going to say. I know you have an upcoming book. So that's exciting. A big one.
Yeah, the book is called, it's called The Science and Art of Musculoskeletal Diagnosis. And it's going to be in paperback to start with. Converting that to an ebook is going to be necessary, but there's actually a lot of work involved in that because it's got a lot of colored pictures and paint drawings, and basically that book consists of two parts, or there's 4 sections. The sections 1 is all about reliability. Section 2 is all about diagnostic accuracy. Sorry, section 1 is about diagnostic reliability and diagnostic accuracy. Section 2 is the art of musculoskeletal diagnosis. That's about how do you translate science, the actual mathematics and statistics of it, into clinical practice. How do you make that accessible to normal clinicians who are not scientists? So how do you go about that process? That's the second section. Sections 3 and 4 are all case studies. Section 3 is the initial assessment of we'll have about 25 patients. So these are patients that have all had diagnostic injections or whatever, or MRIs or whatever, and lots of stuff. But in section 3, we present that patient as they present on the first occasion, the initial assessment. What is the detail we have? What is your clinical diagnosis based upon that? How do you use sections 1 and 2 to arrive at a clinical diagnosis from the initial assessment? And then section 4 is what actually happened. What was the diagnosis? What did the MRI or the injections or whatever tell us? Did we get it right? Did we get it wrong? And what do you do about it? And what was the outcome of those patients? So it's about, it'll be about 350 A4 pages. I don't know how many pages that will translate into a book at this stage, but I'll know within a few months, and hopefully that will be published by August.
That's awesome. Exciting.
That'll be available on Amazon and that stuff.
Awesome.
And through Physio Academy and probably Agile CBP as well. But we will ultimately like to get that translated into Spanish, into French, into Portuguese.
Very good. Very good. Mark, it was a pleasure to have you back. I appreciate your time and coming break down this paper with us. I learned a lot. I'm sure everybody learned a lot as well. And come back for next papers. I know you have lots of papers coming, so we're always welcome
yes,
back.
We have some more coming up. And Jean-Philippe Deneval has been highly instrumental in helping us with that. He and his team are doing most of the analysis, and it's my data, but he's doing a lot of the hard work.
Awesome. Very good. Well, thank you again, Mark, and I'll hope to see you sometime back soon. That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.